solutions getting scaled up to the national level. Last year, there was a statistics which was done by NSSO, National Survey and Statistics Organization, on the health segment, that the rural population which is traveling within India, the patients and their attendants, they are spending close to around 23,000 crores on just the travel itself and no medical expenses which are involved in that. This is just the travel estimate. We have seen a lot of statistics in last 3 days, and this is another statistics, which is much more than the health budget which has been allocated by the central government. So that is how people have started looking at telemedicine, but we have seen a lot of pilots and no real push which has gone. What I feel is that one of the factors is that there has been slightly lack of participation from the government in this particular area, though there have been a lot of committees, a lot of discussions which are happening, but there have been no particular focus approach which has been taken till date. If you see that any new technology which is for use for the masses, like even the telephone which was introduced in country, that was done by the government. Then email facility came in, that was also done by Government of India. Even internet access, that was started by Government of India. This was way back in 1978 when even Department of Information Technology, they set up a new society itself to focus on the email and the internet, which was by the name of ARNet, which turned out into an autonomous society in 1991. So that was a focus approach when government realized that this is a technology which is going to help the masses, and someone has to take the first step, because whatever one may say, the corporates are not going to come into the fray till the time they say viable business model. There will be some of the pilots which will be there, but taking up to a larger shape, the government has to step in. They have to show that there is a market which exists, and then there will be a lot of service providers will come in, which has happened in telephone, which has happened in internet, which has happened in email. Today government is taking the back seat. So government now is scooting out of those particular services, and now they are moving back to the regulation. So government has to create the policies, they have to create the platform so as to attract the people from the industry, so that they come and create similar kind of platforms and then move out on the regulatory mode, which has, I think, not yet happened in this particular domain. If you see success of various projects in other ministries, like I would say Ministry of Home Affairs, there is a project which has been conceptualized by the name of CCTNS, which is connecting all the police stations and police chowkis across the country. It is happening at the state level, and we are talking of the locations not less than 20,000 across the country, which is not a small number by any means. There is a funding allocation of around some 2,000 crores plus, which has happened to that particular connectivity itself. Similarly, we have seen similar rollouts in the power segment, which was the APDRPs, wherein again all the power related units have been connected, and there is a major funding which has again gone in. Similarly, if you see even the eGov initiative of Ministry of India, that has also been took off after the NEGP was rolled out in 2006, and then there was various mission mode projects which got conceptualized, like the state wide area network, the state data centers, the CSCs, the capacity building. So we need to see that which is the particular area we want to focus, and we have to create a mission mode project around that. These are all the initiatives which were done by the central government, but end of the day, the country has been spread into the states. So it has to be rolled out into the states. So we need to take the state also as one of the stakeholders in this particular initiative. NEGP in 2006, there were 3,300 crores which was allocated across various projects. And today, if you see within 5 years, out of 35 states, I believe 25 states have already got the state-wide area networks, wherein the connectivity has gone up to the block level. So today we have close to around 6,000 plus blocks which are already connected on 2 Mbps or above that, which is no small achievement by any means. And if you see at the block level now, a lot of states, they are talking of, this was called the vertical SWAN, and now people are talking of the horizontal SWANs, which are going to connect up to the panchayati and up to the village level itself. Another mission mode project which was taken by Ministry of IT was the CSC, the Common Service Centers, wherein again close to around 97,000 have already been rolled out, and yesterday Mr. Pilot was there when he announced that he is going to take the numbers from 100,000 to 250,000. Now 250,000 means that practically we have a common service center in every third village in the country, so which is already connected, and the purpose is to roll out these kind of services. And in any developing country, education and health is always going to be the most focus area where a lot of investment will come in, and a lot of, I would say, focus here by any government. If you see, coming back onto this telemedicine, how it has to get rolled out, some of the crucial factors which have to be kept in mind while rolling out I would say, a large telemedicine network. I would say when I say large, it is at least hundreds of nodes which are connected. Some of the crucial factors are, first factor is the, I would say, participation by the patient as well as the doctor. Now, doctors are going to participate if the technology is going to be easy to use. We have seen a lot of corporates, a lot of organizations who are pushing people to work from home. This could be something similar to that. We are giving a facility to a doctor to work from any place where he wants. We have seen some of the specialists even in metro cities where a doctor attends 2 hours in one particular hospital, then another 2 hours in the afternoon he goes to some other location, in the evening again he is there. And sometimes these hospitals are at least 1 to 1.5 hours away. So these kind of specialists are wasting at least 2 to 3 hours just traveling within the city. We are talking of major metros. These 2 to 3 hours can be used in delivering those kind of medical services to the rural or rest of the community. For what we need to enable is, we need to enable certain devices so that he is able to offer the teleconsultation or telemedicine, whatever services he wants to offer by ease of use. Whether it is a laptop, whether it is a desktop, or whether it is a tablet PC, he should be able to connect to whatever mode of connectivity, whether it is a Wi-Fi, whether it is a 3G, or whether it is some landline connectivity or MPLS. So it has to be media independent. The doctors are not expected to know the IT equipment and how IT is going to work. It should provide them ease to use, that once they start working, they should not be able to spend even 2 minutes or 5 minutes just setting up that particular equipment. So that has to be most important factor, so as to get the involvement of the doctors into this particular process. From the patient side, why we have seen a lot of hesitations that patients prefer to meet the doctor in real life, because that gives them the comfort. If you see in terms of the comfort factor, people who have been using video conferencing as a technology, they'll feel that we get close to around 80% of the comfort as compared to the real life interaction. There used to be telephonic communication also, or teleconferencing which used to happen, which used to give the 30% of the comfort. These are some of the statistics which have been published overseas. But video conferencing can give you 80%. But it will only give you 80% comfort provided you are getting the right quality. They should be able to see the doctor properly, they should be able to hear the voice, so that they are confident that whatever they are speaking, it's getting heard by the doctor, and whatever doctor is saying, it's getting heard by them. If someone who is hesitant to go on a telemedicine infrastructure, he doesn't get the right kind of quality, the voice breaks or the video breaks, next time you can never get him back. So that things have to work first time, because anyway there are people who are hesitant to use this particular technology. So we need to ensure the quality of the infrastructure is up to the mark. Apart from this particular, I would say, the human issue, then there has to be infrastructure which has to be created to deliver this, one at the doctor end, one at the patient end, and then there has to be a connectivity in between these. The infrastructure will include the components from video conferencing like Polycom. You mentioned that they have been one of the major vendors who have been offering the entire range of solutions, right from the, I would say, the software-based client, going up to the telepresence and real presence-based solution, which can be used as per the requirement of the organization. So they have the vast portfolio, and there are similar other vendors who have been offering this particular thing. So this is something which is required at both the ends. Then we need the medical equipment as per the requirement of that particular consultation or that particular telemedicine. Now, telemedicine I would like to categorize into various tiers. Telemedicine is something we heard the armed forces people yesterday. They were saying when there used to be a war in Kargil, they used to provide the consultation over the phone. So that was the simplest or easiest means of telemedicine. Telemedicine is nothing but delivering the medical advice over some kind of a communication. So that was the simplest way. Next comes in teleconsultation. Teleconsultation, being a subset of telemedicine, I would say, is nothing else just because other than the video conferencing. There have to be two people who have to talk, and these particular two people can talk once video conferencing is in place. Third, or the most advanced thing is required when you have to capture or you have to do the diagnosis of the patient in the real time, where we have a lot of equipment like you would have seen in the stall of Global Met, the first stall which is there. We have showcased various equipment, which are the digital stethoscope, where a doctor can hear the heartbeat of the patient sitting even thousands of miles. So there is a headphone which is provided to the doctor. There can be a local end also, where the paramedical staff which is at the place of patient, he can also hear, as well as remote doctor can also hear. We can capture the statistics or the diagnose the ECG We can do the ultrasound, we can do the X-rays, we can do, I would say, ENT examination, otoscope. So there are a variety of equipment, and that is the, I would say, the highest form of telemedicine, which per se, with our interaction with so many customers in the last couple of years, we have seen out of the requirements which come as telemedicine, per se 60% are only video conferencing. Only 30 to 40% require the real form of telemedicine where you need to actually deploy some sort of medical devices. So this is something which needs to be deployed. And then third and most crucial thing is the bandwidth. These locations have to be connected. So you need to have a seamless bandwidth, which is good enough to take care of any video conferencing requirement, like standard definition used to require 256 to 384 kbps. And today the advanced technologies for high definition, I'm sure Mark is going to cover that in the next session, as H.264 high profile, which is going to offer you the high definition quality at 512 kbps, which is today not a challenge. 5 years ago, there used to be, most of the organizations used to have links of 64 kbps, but that is history now. People today have 2 Mbps or above than that. So this particular bandwidth has to be seamless so that that particular,
yeah. We have about a couple of minutes.
Yeah, sure. So that is something which needs to be put in place so that good quality of service can be given between the patients to the doctors. And today I am happy to see one of the service providers who is there in the sponsorship list. We have been participating with Telemedicon for almost last 5 years, and this is the first time we are seeing a service provider. So service providers are also trying to bring in the focus on this particular initiative. So what I would say is, like the success of other mission mode projects in other ministries, we need to have a mission mode project around this particular technology also. So we need to have, let's say, something like state telemedicine network, which needs to be rolled out in all the states, because ultimately health is a state subject, but at the same time center has to support that. Like center has supported all the other initiatives across the ministries, they need to support this particular initiative so that a platform should be shown. Not only these particular things, we have, I'm sure that everyone is aware that there are a lot of e-gov projects which have happened across the country. The largest being, which was for so many years, was the e-passport saver. And after that, we have another rollout which has happened in the health segment. So the largest e-gov project of the country today is in the health segment, which was done by ESIC itself, which is connecting close to around 1,500 dispensaries and 140 hospitals at this point of time on a bandwidth of 256 kbps, upwards of 2 Mbps at various locations. And this particular ESIC, they are catering to a population of 5.5 crore people in the country, across the nation. So they are the organization which has got a ready platform, and they have a population of 5% of the country. 5% of 1.2 billion is not a small number. They have the infrastructure which is ready, 1,500 hospitals across the country. It means practically they are multiple in every block. So this kind of penetration is there. So these kind of organization needs to scale up to absorb telemedicine. They have spent $300 million in these kind of initiatives, and still they are not able to deliver the medical services to the people in the rural area. And those 5% of the people, in case they can get these kind of services, this is going to be a huge, I won't say pilot, I would say it's the biggest rollout across the world. And similarly, we can have any state-based rollouts that are going to give a great push to these kind of telemedicine initiatives. This was more from the government perspective. From the corporate perspective, we need to have some sort of a service providers, I would say telemedicine service providers, who can offer a single point of service to a doctor. Last month, I got a requirement from one of the doctors in Delhi. He has got 23 eye clinic across the country. He wanted to connect. We work out a BOQ. It was an investment of 1 crore, which is not a small investment. For someone who is going to take a plunge into telemedicine, in case it doesn't work out, his investment goes down the drain. So we need to have a service provider who takes the ownership that I'm going to create this thing for you. You start using that and pay me on a usage basis. So that is what is going to push this telemedicine technology going into the volumes in the private and in the government segment. So those were some of the thoughts after going through this session of 3 days. Any questions on that? So that was it from my side.
Okay, so thanks very much, Mr. Giridhar. I think you have succinctly put together the challenges faced by telemedicine and the problem related to the ecosystem, the way in which this whole telemedicine ecosystem is developing. There's a lot of impaired components within the development, but as long as there is an intense need for telemedicine in the country, I think this will really see the light of the day, though its progress is relatively slow, but I think the way in which you have described some of the examples it looks like there is a groundswell, and we definitely would see something positive happening in the years to come.
It all
Any
depends on
questions
the,
from here? Sorry.
it all
I'll
depends
just,
on the
we
return
need
of
to,
investment, what you are saying. The faster we get return of investment, it will motivate the people to
yeah, it
get more
depends on
into
how well
this.
the ecosystem develops, and there's
That's
a
true.
leadership that has to happen.
Right.
Like the way it happened in telecommunication industry.
That's true.
Uh, See, there's a lot of, amongst the competition, they work together to set up the towers, right, instead of fighting. The towers was a major critical bottleneck,
True.
and they invested what they call the Indus. There's a company that was formed, and then the towers were supported by all these companies. So there must be, what will happen is that I guess a leadership will emerge, as long as we see a business model which is viable, and, but you have successfully put together all the challenges.
I think that would be the last step when we have so many telemedicine service providers and then they try to collaborate on that.
Absolutely, terrific.
Right.
Thanks very
Okay.
much.
Thank you. Yeah.
You can have the questions at the end of the sessions, so I would suggest you to stay back till the end of the session. Next, we invite Mark Alexis Raymond, Polycom. Sorry, yes.
I mentioned one thing. Any of you, I'm in the next session, the next door. Any of you would be interested in learning more about Continua? Come on next door.
Okay, sir, so you have about 15 minutes. Thank you.
Thank you very much. Good afternoon, ladies and gentlemen. It's a pleasure for me to be here with you and share with you a couple of things. Some of the new technologies as well as some of the new initiatives that are happening worldwide to address this challenge of urban and rural divide in areas of health in particular. And I'll take the opportunity to thank Krishan for laying the foundation for my presentation, as he covered a couple of things already. But he gave you the context of India, and what I'll do, I'll give you a more global context to that, and you can perhaps learn from what is being done around the world. And around the world, you know, countries face similar issues. It's the issue of bandwidth, it's the issue of access, quality, and equity of care. And it's not just care, it's education, it's access to government services overall. Okay, so what we've done from a private sector point of view, we try to bring to the market, to the healthcare providers, new technologies that will help address the challenges. And when bandwidth is one of them, we integrate new standards that will limit the utilization of bandwidth when video is required. So Krishan mentioned that there is a protocol. It's a bit complex. It's called H.264 high profile. But what it does, it pretty much reduces by 50% the amount of bandwidth required for a high definition video conferencing call, right? Now, most of you have probably high definition TVs and full HD TVs. Well, in some cases, a high definition image is required. Not for everything, but in healthcare in particular. So I'll just go and look at, you know, the red bar over there. You know, standard equipment would require 1 megabit of bandwidth for a basic HD call. With this innovation called H.264 high profile, if you look at the green bar, only 512 kilobits per second are now required, which is enough bandwidth available in many areas throughout different countries. Now let's look at full HD, which is what we call 1080p. Well, normally you would require 2 megabit of bandwidth for that video consultation to happen. Now only 1 megabit is required. Now, some of you may be using standard definition and would like to understand why high definition. Well, let me share simply with you that high definition, it's basically 3 times the quality of standard television, right? And it's also 9 times the quality of traditional video conferencing, which makes a lot of difference when you have to share medical images, whether it be videos or still images from point A to point B. We talk about access, right? Access to public services in general. And what I have seen worldwide is this concept of citizen service centers, e-community centers, or even local government units in certain countries. And what governments are trying to do is to have this one place where citizens can go to and have access to all kinds of services, whether it be for education, health, social services, justice, or even trade and civil services overall. And what we're working together with them is to enable all of this using video technology, right? So that from that particular center, you can have access to any kind of government department throughout the state or throughout the country in particular. So if you are a patient, you can have access to a doctor via video and be provided the care that you need. By combining all those services, when I say health, education, trade, justice, it's the same infrastructure. Why would we want to build silos or platforms that are separate from each other when all of this can be combined in order to reduce the overall cost of it and share that across the different ministries? I have a good example in the Philippines, the Department of Agriculture. They were looking at a video conferencing solution for their own use. But after we discussed, they realized that, wow, we're spending a lot of taxpayers' money just for us as a Department of Agriculture to communicate internally. So they quickly turn around and say, how can we make that infrastructure available to the people? So now what's happening in the Philippines, they have opened the doors to those video conference rooms so that farmers and fishermen can have discussions with the traders in Manila and some of the big customers overseas as well. Nobody would have thought, at least on the fisherman side or the farmer side, to invest in a video conferencing equipment to communicate. But this will help overall to improve and help the trade to foster in the community. So there are different type of solutions that can be installed in rural clinics to provide that teleconsultation Christian was talking about, for disease management, but also for awareness and education in all areas, but also, you know, to provide some public service updates as well. Of course, for clinical environments, there are more sophisticated solutions, like the one you see here that can be moved around the hospital or the clinic, to which you can attach any kind of medical peripheral, whether it be an exam camera, a stethoscope, an ultrasound machine, and so on and so forth. Now, what I would like to share with you now is a short video that will show you how in the US they handle emergencies in rural hospitals. That will give you an idea on how the technology is used and how it can help rural areas, hospitals in rural areas that may not have the resources required in certain cases.
It's no surprise to most of you that doctors can now read x-rays or share medical records over the internet. But did you know that they can also perform emergency room medical services on the web?
Yeah, it's called e-emergency, and it's saving lives and cutting healthcare costs in Minnesota and across the Midwest. 5 Eyewitness News reporter Tom Hauser shows us how it works, new at 10.
Were you on the ambulance with her? You're looking at the future of medical care in America.
When you push on the chest wall, does she have any pain, Kathy?
An emergency room at a small Iowa hospital.
We have no radiologists.
Dealing with a sudden influx of car accident victims.
A semi ran into a car.
But the staff in this small ER...
The car has four to six passengers. I can't quite get the number, and the EMS doesn't know.
...has a new and important backup system.
We have both helicopters.
An ER doctor and trauma nurses at the much larger Avera McKinnon Hospital in Sioux Falls, South Dakota, are watching every move from 50 miles away.
If you had a time to shoot a portable chest x-ray, that would be great.
It's called e-emergency. The entire staff of medical personnel and specialists at a much larger hospital.
Hello, Dr. Koziak.
Linked via internet and two-way video hookup to dozens of smaller hospitals. They can monitor vital signs, look at x-rays, even zoom in on injuries. Hospitals pay to subscribe, patients are not billed for the service.
You've doubled the physician that's in the room. You've doubled or tripled the amount of nurses.
Deanna Larson of Avera Health says they deliver e-medical services to hospitals across the Midwest, including nearly a dozen in Minnesota, from Marshall to Baudette.
At any point in a 6-state region, you could have something catastrophic ongoing in one of those facilities.
The goal of e-medical services is simple and threefold. Help patients survive, let small hospitals thrive, and save the healthcare system millions of dollars.
Following up in the clinic there is a good idea.
Dr. Don Koziak says about 25% of the time e-emergency is called on to help, doctors in Sioux Falls are able to advise hospitals not to transport the patients.
They stay local to get their follow-up care. They stay local to be by their loved ones and to generate income for that hospital to help keep the doors open.
So I'll stop it there, but I think you're getting the idea of how it can benefit rural hospitals when they have a sudden increase of cases to handle, and they need to reach out to a center of excellence to get the expertise in a minimum amount of time. The other solution I would like to share with you is something that we are working on with a company called Home Video Care in the US. And in the US, it's meant for home care, right? But we know that in countries in Asia, that may not work, right? But I think this may have a potential in some of the rural clinics as well. As you can see, it's a phone, so you have voice communication, but it's also a video phone, so you can have face-to-face communication between the patient and the doctor located remotely. This phone also can receive information from different devices via Bluetooth technology, and those patient data can be, of course, be forwarded to a server somewhere and be integrated with electronic medical records, for an instance. There are other applications that can sit on the phone, such as alarms to remind patients to take their medicine, or even additional services like shopping and so on and so forth. But I thought of, showing you to understand that there are different types of solutions that can fit in a rural environment, not necessarily the high-end types of solution required, but very simple solutions such as a phone can pretty much do the trick in many, many cases. And of course, there are much more advanced projects that we're working on where you're talking about mobile hospitals, right? When hospitals are not available in certain areas. And here it's basically having a complete vehicle with an operating theater and all the equipment required to perform surgery and any care in any area of the country, especially in times of natural disasters. Okay, so we have many case studies that we can share with you in terms of rural health. This is the case of the Open Door Community Health Centers in the US, where you have 10 clinics in remote areas where they have face-to-face conversation with specialists. And we have other takes in Texas, for instance, where here it's much larger. It's 108 counties in Texas being connected to a main center of excellence, so to speak. So on this, I will end my presentation. But of course, I thank you for your attention, and feel free to ask questions later on.
Thank you. Any question? I think it's a fantastic presentation, so it would be great if we can ask questions and understand how to make this come alive in India, rather than limiting it to the United States. Any questions? So my question to you is that how easy or difficult to make this happen in India? Most of the example that
which part?
Most of the stuff that you talked about, mobile surgery or having the patients out there, somebody's not fully equipped to deal with that, but somebody on the other side helping them to deal with the trauma cases, right? There's a lot of stuff that you showed. Many of them are applicable to India.
Yes.
So tell me what can we do in India?
If we talk about e-emergency, as long as the main hospital can be connected in a certain way with a rural hospital, this can be deployed tomorrow. It's just a matter of, having the main hospital partnering with rural hospitals and finding the business model where they would define how to cooperate, how to provide care, and so on and so forth. But this needs to happen at the local level. The example we have in the US, they say it's a free service that they offer to rural hospitals. Patients remain there, come back there for follow-up. I think those are workable models as well for India. If you're looking at the Citizen Service Center, where you have all government services, let's say, hosted at one place for the people, that requires a strong collaboration among different ministries at the state level. And today, the statewide area networks provide the connectivity. So you could have education, health, and others working together so that the tele services, so to speak, in all areas can be delivered through those centers per se.
Terrific. Have your team, have they met anybody in the health ministry?
We have met a couple of...
Nothing moving? What I would recommend is that if your team is out here in India, I think we should go and meet the NRHM organization as a ministry, and also we should get a chance to go and meet our health minister.
Sure.
So I'd be very happy to talk to your UMSOR as a local person, or if you are there, I think we should go and meet them and tell them so that they can visualize what they can do to our population. So thanks for this presentation.
My pleasure.
Looking forward
Thank
to
you
take it
for your
forward.
attention.
Thank you. There's the last topic, but it's a very important topic, which is very important to the country. Maternal mortality rate is pretty high in India. There's a lot of work that's happening, IMR and MMR. But I'm really delighted to have Dr. Jaya Singh. She's going to talk about Save a Mother Foundation. Thank you.
First of all, a big thank you to all the troopers who are still here in the room, waiting for the last presentation of the day. Just give me a second to be set up. All right, so I'm here today with Save a Mother. It's a non-profit, and our mandate here is to keep the poor healthy and to do it in a cost-realistic manner. We all know the problems, right? We know that to go from sickness to health, India needs solutions that can be deployed very fast, very speedily, and we also need to attain scale. Whenever you talk about scale, there is a hope that IT is somehow going to reduce the disease burden and is going to solve a lot of our problems. But when you try and triangulate what exactly IT can do in rural populations, I think you come up with a grid like this. So you can think for disease prevention, it can help in health literacy, disease surveillance, perhaps providing care at point of intervention by means of telemedicine and kiosks, and of course the whole benefit from using IT in processes and so on. And so from our perspective, our view from the trenches, what can IT do for us in rural communities? Set of 7 things that we can think of. It can help in education, provide a helpline, diagnostics and treatments, communication with healthcare workers, disease tracking, remote monitoring, and data collection. That's the view from our world. And there are plenty of case studies, compelling examples deployed throughout the world, and I won't go into that. I'm sure you've seen this over these past 3 days or so. But for example, data gathering on dengue on the phone in Brazil, text-to-change for educating AIDS patients in Uganda, compelling models of primary care in Peru, and then Medic Mobile that came out of the US and is deployed in over 40% of Malawi district hospitals. In India, there's been plenty of work done in the telemed, telehealth arena, and we've created services, equipment, applications, and big consortia of public and private players to move IT into rural communities. One example, I think that's been successful at providing intervention or delivering care at point of intervention is the Arogya kiosks that are deployed in Rajasthan. And what they do is they provide algorithms for certain common ailments operated by someone from a village, supervised by a physician, viable business model of 12 rupees per visit. business model was published by a group from IIT about 5 or 6 years ago that connects right all the way from the village kiosk to your technology, through the healthcare provider, through telemedicine and the technology providers. So the question is then, can kiosks, can telemedicine really deliver? Can it reduce disease burden in rural India? The answer perhaps is yes. And I'm going to wager in this audience that it has to come hand in hand with human intervention, because healthcare doesn't work effectively without human intervention. That's been our experience in the field. And the other burning question is, at what cost are you providing IT? At what cost? Is it realistic? Is it sustainable with or without government subsidy? But what business models might you be able to build to make this whole proposition viable? So I'm going to move away from IT, the next part, and describe some of the initiatives that we've taken at Save a Mother, and pose it in a way that, is it possible to have an impact on rural health, deep impact, real quantifiable impact without the use of IT? So at Save a Mother, like I mentioned, we're looking at keeping the poor healthy. So we are always thinking of devising solutions for the poor, healthcare solutions for the poor. And the first area of focus we started, this is a fledgling organization, we've been in the field about 3 years now, was maternal health, maternal and child health. That's the first problem we picked. And I'd like to share with you the results that have come out of this work with our team. The philosophy by which we approach healthcare in rural India is that health literacy is the least expensive means of reducing disease burden. Also, if you approach health as a responsibility over a human right, it is a more sustainable model for propagating health literacy in communities that we work in. And I think these two methods have really been the cornerstone which have made our method simple, sustainable, and scalable with speed. What is it that we do? We keep it really simple. We just break down what you need. Just like the 7 habits of highly effective people, we've broken it down into 7 habits of healthy people, and conveyed this knowledge to rural communities in a format that they can understand, assimilate, and internalize until it becomes part of their daily practice. And that has really been key to the success of our program. This sort of low-cost social marketing techniques, intense, repetitive repetition of key information that you need in order to keep yourself healthy. What are the main areas we touch upon? That you should hold regular meetings in the community to identify problems in the community. We talk about personal hygiene, things that you and I take for granted, cut your nails, boil water, simple things, knowledge that has existed for 100 years, but no one has it hasn't made it back to the community still. We're not talking about 21st century problems, we're talking about problems of the 18th and the 19th century, really. So we talk, and then for maternal care, we teach our populations just 4 basic things. Take 100 iron tablets, make sure you get 3 visits to the hospital. We promote institutional delivery, and in essence, we are driving the demand for public health by connecting pregnant women to existing services that they can utilize, which are currently underutilized. And there are also modules on childhood nutrition and so on. But the key, again, is it's done in a format that makes sense to the communities where we work in. So all our materials, flip charts, graphics, are designed in the village by the villagers, produced and printed in the village. So there's a real sense of ownership of material. We also teach through songs and slogans that each village actually comes up and devises on its own. And that's really been very, I think, essential to the kind of impact that we're seeing now. So there is our health activists undergo, and these all health activists, we have about 1,300 health activists in the field right now. Every single one of them works as a volunteer. So these are women from the village who are not highly educated, who are not paid a salary, but they're motivated enough to keep our program sustainable. So training is intense, repetitive, there are a number of meetings, there is house calls, each pregnancy is tracked. There is robust data collection, and data collection is enabled through our healthcare workers. And it's interesting because a lot of these women are not educated, they've barely made it through 6th grade. And now they're actually going out and collecting data on population, healthcare expenditure, complications during pregnancy. There is absolutely no use of IT in this methodology. Even in tracking pregnancies, there is no hand-holding, there is no reminders by phone or so on to ask a woman to take her iron tablets or go visit a physician. So what has our impact been, again, with this very low-cost method? In less than 3 years' time, we've seen a 93% reduction in the maternal mortality ratio, over 60% reduction in newborn deaths. Okay? And the cost at which we've been able to achieve this, thank you, is actually under less than 5,000 rupees per village per year. That's the true cost it's taken for us to get these results. That's the good news. It's also a scalable solution. In 3 years' time, we are in over now 1,000 villages. We have about 1,300 health activists in the field, and currently our program is growing at the rate of 1 village per year. So we feel happy about this result. We can pat ourselves on the back. But here's another slide that puts this whole everything I described to you into perspective. Expanding at the rate of a village a day with the resources, financial and manpower resources that we have, to cover all of India, 600,000 villages will take over a millennium. It's not possible. So we're back to the problem that India needs scale, and we need to do it really quick. So the challenge of scale is, can we use IT as an amplifier? Like I said before, telemedicine by itself, rural health IT by itself cannot deliver. It has to be hand in hand with this grounds work, and really try and leverage existing technologies as an amplifier. So we've broken down the paradigm of finding developing solutions for healthcare into 3 main cycles. So there is the data collection cycle of identifying problems in the field, analyzing this data, reporting it, collecting it, which in my mind is not the big problem. And it's been done for years, whether you do it on paper or electronic. It'll lead to refinement and perhaps more accuracy, but that's not where the big leap is going to be. But however, this data collection feeds into a knowledge repository, and our challenge then is to take this knowledge and then push it through barriers that have existed. There are social, cultural, and technology barriers to bring it to point of care and to innovate these delivery solutions, which I think has been the crux of need for technologies like telemedicine and so on. So what are we doing? How are we approaching it? The data collection piece, we are instituting right now. We are formulating and setting up a rural health IT system in collaboration. Again, this is a consortium with folks from CDAC, Intel, Indian Association for Medical Informatics, and a host of medical and IT professionals, with the hope that now we can get access to our own data at the individual level and also at the public health level. This data will feed into a knowledge repository that we are working on and building, right from low-tech print media to DVDs, low-cost films that are not very expensive to produce and disseminate nowadays, and also touchscreen kiosks. We're also launching a program on telemessaging, a pilot to see how effective it is and and we're always keeping track of the cost. How much does it cost and how much of a difference does it really make, impact it has in the long term? So we are starting these pilots in the villages that we work. For health delivery, and this I think is crux to, if you want to move India from sickness to health, we've come up with a module of a plug-and-play module, if you will, of 25 sectors, 25 modules that can provide a self-sustaining ecosystem. They include preventive services, ambulatory services, curative, and then sector-wise interventions, and then, of course, logistics, resources, and so on. For now, we focused on health education, and within sectors, maternal and child health, but we are now moving into TB eradication, population stabilization, and our plan now is to set up these Save a Mother innovation zones. Now, these are not theoretical, these are not going to be labs or a physical building where we are carrying out theoretical research, but they will in fact be groups of 500 to 1,000 villages that are places of dynamic action for rapid prototyping and testing pilots of what have you may for developing. The focus is always healthcare solutions for the poor. They may be social persuasive techniques, behavior modification programs, the use of ICT, cost-realistic ICT, and then, of course, the whole slew of other health-related problems that we need to address. So I'll just take a step back. A lot of slides that I covered very quickly, but our conclusion, our view from the trenches is, from our perspective, what is it that rural health IT should deliver? It should make information freely and transparently available. It should decrease disease burden. We should be able to manage disease, and very importantly, to make this whole effort sustainable, we have to be able to manage cost. It's just references. And so I'll just end by saying that from going to sickness to health, ICT by itself is not a standalone solution. However, we cannot afford to ignore it, and scaling is going to be possible with ICT, and time will tell what technologies stand the test of time. So thank you very much for your attention this late in the afternoon. I'll close by saying that this is almost an entirely volunteer-run organization. I'm also a volunteer in the group, and we're always looking for people to volunteer their expertise and time in whatever form, manner that you may have. So thank you again for your time.
Thank you. So definitely telemedicine requires just more than technology, it requires passion and commitment. Thanks very much. I think this was a terrific presentation. Definitely it should not take 1,000,000 years to reach all the mothers. Any question from the audience? We have 3 minutes to conclude, so any question, I think she should be happy to answer. Yes, sir.
Thank you very much. Very good presentation. Actually, yesterday I did this very similar presentation here. My field is UP, Kushinaga, and only 3 hours in the morning and 3 hours in the evening electricity. Then I'm trying to utilize some continuous device to data collection under 2G GSM. But the slight issue is I'm Japanese, then we are funding one hospital by NGO, but the surrounding hospital is public. And ASHA and many workers there. And always we have to be very careful not to too much doing, and otherwise public hospital people will upset. So do you have any conflict with other sectors?
In fact, we do the exact opposite. We partner with whatever NGO works there. We partner with ASHA workers, microfinance, and so on, because that really amplifies our effect. It helps them, it helps us. And we've been very successful and fortunate in forging those relationships.
Okay.
So we can talk offline also,
Yeah.
because our projects are also in Uttar Pradesh.
Thank you very much.
Any other question? Okay, so I just have one question, is that you mentioned about, covering 3 lakh villages. So I'm told that the maternal mortality issue is primarily related to some part of India, not across. Like, for example, the MMR rates have improved significantly in southern part of India, in Maharashtra, in Gujarat. I guess it's something to do with some portion of the country. So is it a good idea to focus on those where it requires a high impact? Is that something which you thought about?
I'll tell you that worldwide, highest number of maternal deaths in the world take place in India.
Right.
So we're not even close to meeting Millennium Development Goals and so on. Uttar Pradesh, the most populous state, has the highest maternal mortality ratio. 1 in 42 women in India, in Uttar Pradesh, may die during childbirth. That's a statistic that's just not acceptable. And because of the population of the country, it's not statistics of small numbers, it's actually a big problem. And it's a basic problem. If you don't take care of one of the taglines that we have, and I really believe in this, is if you save a mother, you save a family, you save a community. So mothers and children are very important to the long-term growth of any nation. It's not a problem you can ignore.
Terrific. And I'm quite sure that there will be enough support for what you do. I think it's a terrific, big service to the country, more than what you do for the IT industry. So thanks very much. And if you don't have any other question, I would like to thank all the speakers for having contributed to this meeting. Thank you.